Oh, how lovely to be here in Cardiff in Wales. Gosh, so lovely. Right, so yeah, the first session today is on a condition called Hidradenitis suppurativa. And I always ask at the start of the sessions that I've been doing on this, and I think we're on about number 25 now, talking about HS. Who in the audience, just raise your hand if you know of the condition, because it might affect you in a personal way or in a patient's way, if you are aware of it. Just a little show of hands. Not so many, and we've got, obviously there's a lot of us here today, and I can tell you at every session that I've done, we often just get a handful of people who at the beginning are very aware of what HS is, and then the majority of the people in the room, not so. But I think by the end of this, you will think, I've seen this before. I've got patients with this, I think you may, because it's often misdiagnosed. And I will tell some patient stories. Obviously, I've got that with consent to tell you throughout. And sometimes, obviously, because it is a devastating condition, and if it does affect anybody, please do come and speak to myself afterwards or to Mark and Georgina on the stand at day long as well. Just to check in the audience, have we got people from community nursing? Yay, that's my background. Have we got people from acute trusts? Yeah, nursing and care homes. Practice nursing, dermatology. No, good. We're picking me up on this. Anybody else from any weird and wonderful private nursing? Fantastic. And we have A&E, brilliant. Student nurse, fantastic that you're here. And I have a friend who's a tissue viability nurse right over there in the corner, so brilliant. So without further ado, let's move on. So HS, we're going to look at what a devastating condition it is. We're going to outline all those clinical features to aid the recognition. We're going to look at the impact to the patient's quality of life, discuss what are the treatment options that are out there, any practical advice for successful wound management, which up to now has largely been lacking, and help to raise that awareness so we can support and improve early diagnosis. So what is HS? Well, it's a chronic inflammatory follicular disorder, and it presents with painful boils, abscesses, and then runs into tunnels and creates lesions and wounds. It has, such an effect, and as I said, we're going to look at that throughout. It always appears after the onset of puberty. So that's young people. If you think of people going through puberty and, often around sort of 12 years old, that sort of age, sometimes even younger. So this is people who are going into their children, into adolescence and early adulthood. It doesn't disappear, it's a lifelong disorder, but there are certain conditions where it will, the flares will then reduce in a person's life. But yes, so, it is important that we bring it out of dermatology and into our general nursing world, into tissue viability, and start to look at it where we can all manage this much better together. It is a myth that it is caused by, if you hear anybody saying that it's, we went to the GP and we were told it was caused by poor hygiene, or it's overuse of deodorants, it's because somebody's overweight, they are myths, and we'll dispel those myths today. So these are the common areas that HS usually occurs. So common areas are normally in the axilla, so under the armpits, in the groin area, around the buttock area, can be kind of around the under the breasts. There are also less common areas that we can see. And I spent some time at the HS dermatology clinic in the Royal Salford up in Manchester. And we had a day of patients coming through, and they asked me to come to look at the patients and to aid them from a wound care perspective. We had the plastic surgeon that day as well, because he was looking at, would that be of any benefit? So really interesting day. But we had patients who had advanced HS, and they also had lesions in areas like the back of the thigh. There's a kind of around the breast, there's peristomal areas that, so, well, we've got some photographs coming up where we can show you of, atypical areas. So it doesn't always have to be in the areas where we typically think of the sweat glands and the hair follicles, because, that's the starting point for the recognition. So what's the pathophysiology of it? Well, as I said, it's a disease of the hair follicle, so the hair shaft. And we've got that diagram there of the section of skin, which I'm sure many of you are familiar with. So in the section of skin, we've got that top layer of the epidermis, which is 3 millimeters thick. And then we've got the dermis layer underneath that. And in the dermis layer, that's where we have the hair follicle roots. And we've got, blood vessels, we've got nerve endings, lots going on in the dermis. And then below that, that's where we get the subcut fat and then bone and muscle down below that. So this is where it's occurring in the dermis. I like to think of it as an analogy like a volcano, because it's all rumbling away underneath the surface in the dermis where we can't see it. And so what happens is that the follicle inflames, we get an increase in the lymphocytes, we get hyperkeratinization of the follicular epithelium, so that is just forming a thick plug, and then we get the occlusion of that, and the dilates more, and then what happens? Like in the volcano, woof, it erupts, and it comes through the surface of the skin. Now, it doesn't just appear in like one area of like one boil or one abscess, then it forms under the skin, these tunnels, these tracking tunnels. And you can feel that in patients when you see them. You can see they've got, one lesion or two lesions, and then you can feel where that tracking is occurring. So what's the occurrence of HS? What do we know about it? Well, it's not a rare condition, even though, and I think that's part of the problem. It's difficult to say, isn't it? Hidradenitis suppurativa, and also, people just assumed, well, it's a rare condition, and kind of where does it sit? What is it? Oh, it's dermatological. But we know from data being gathered, and more data being gathered, we're learning so much more, that it affects about 1% of the population in Europe, 4% globally. And you might think, well, that's not much. But if you put it into context, there was a study done in Ireland, and that study found 1.4% of the population had HS. Now, when we're talking later about venous leg ulcers, and the data we know from the burden of wound care in England, that's the same. And we know what a big problem that is. So HS is an issue, and we don't count it on that burden of wound league table. So we don't know what the financial cost is of it to the NHS. We're probably underestimating the amount of people with it, because it's getting such a delayed diagnosis, and people are. It's like if I say people are, starting with their first boils and lesions and identifying that around 12 years old, and they're not getting diagnosed till they're around average 22. That's a lot of people who are out there with this condition who have not had the diagnosis, or even getting missed diagnosis too. So this is some images of different stages of HS and how it presents. And there was a consensus paper done in 2021 which looked at all the and labelled all the different the nodules and abscesses, and there's plaques and the size of them and the shape of them, just so we can differentiate it from acute abscesses and acute cysts. Also, it presents in early stages as comedones, which you and I would know as blackheads and whiteheads. So you can see how it then can get misrepresented into something like acne, teenagers, Also, it often gets misdiagnosed as pynoidal disease, and I'm sure many of us have helped patients with their wound management after having pilonidal surgery, and they might have had surgery and surgery and surgery, and it's like, it keeps coming back. What's going on? Maybe it's HS. Subcutaneous Crohn's is another one that it gets misdiagnosed as well. So people will often go down a route of blood tests and exploration and referrals maybe into colorectal services, and that's okay because we need to rule other things out, diabetes, but it's taking too long to get to the point. And we can see the far images there at the bottom is when we have got real advanced wounds and tracking and tunneling going on. So again, that's just the anatomical locations of the typical areas of where HS occurs. And as I say, the people who were coming into the clinic, they did have these areas, or they'd had it in these areas, and then were left with scarring disorder. And then they were kind of, they were coming up in the other sites as well. So here we have some images of those atypical areas. So we can see we've got areas on the face, we've got the back of the neck, we've got that chest plate, we've got the foot, many different areas. And a young chap who was 21 came into the clinic, and his chest was like that, with scarring. 21 years old, just full of scarring. Yeah, and the scarring becomes very tight and taut. One lady came in and she had a toddler with her husband sat in the corridor outside. She came in for an appointment, and we needed to look under her arms because that's where her lesions were. And she was like that. She couldn't lift her arms up because of the scarring was so tight and taut. And she said, I can't pick my baby up. This is how it's affecting people's lives. So we don't know why HS occurs. Maybe if we have more funding into research, we might get more information about that. But at the minute, we don't know why. But there are certainly risk factors associated with it and comorbidities that seem to be stronger in people with HS and will therefore increase their flares. So we know that there is a genetic link. So often you will see that it runs in families. An immune response, so people with immunological type of disorders, hormone influence. Now, this is very interesting because in females, and it occurs about 3 to 1 ratio of females to males. Not to say it doesn't occur in men, because it does, and I've seen it. But after puberty, going into puberty, and then when people are menstruating, the flares go up. If they go through pregnancy, it goes down. So women say, well, it kind of disappeared, and then I was in my 30s or whatever, and it came back again. When people go through the menopause, they describe to us that again, it kind of slowly and into the, kind of the 60s, sort of seems to peter out and reduce down. So definite hormonal link. Now, obesity's on there, and it's kind of like, obesity, because of the metabolic disease, there is a prevalence. There is, the friction of with skin folds will increase flares. But it is not to say that obesity is a cause. And there's certainly people I know with HS who are thin as lats, they don't smoke and everything else. But the people are, sometimes told, well, you need to lose weight. That's the cause. It's not as simple as that. Now, smoking, again, this is a good one. So I need to look at this. I have to write things down in case I just sort of forget, and I've got so many facts and figures and things to share with you. But this is a really good one for the smoking. So a lot of people with HS either have been smokers or do smoke, and they say that the alkaloids in cigarettes are able to promote the Staphylococcus aureus proliferation and to change the microbiome of the skin. And one study I found was on taking biopsies of the skin of people with HS and not with HS, and their microbiome of their skin was much higher in the people with HS. So maybe there's some linkage there. And also the secretion of nicotine into the sweat can lead to epidermal hyperplasia and cause a follicular occlusion and decrease the macrophage activity. Now, macrophages are the Pac-Men of the wound care world, and they come along and eat all the debris up when we're getting all those white blood cells. And the others who are talking later today, Simon, and they'll be talking about that, how that happens. So yeah, so some interesting research facts around smoking. Some people say, does diet help? Again, there's small case studies that sometimes high sugar or high yeast in diets can increase flares, but you know, I think having a good balanced nutrition in all our lives is a good thing, isn't it? So what's the diagnosis? How do we diagnose HS? Well, it's primarily a clinical diagnosis. So as I said, there are no tests, so we can't do a blood test. Swabs, people always say, could we do a wound swab? The wound swabs are often non-pathogenic, so that is one of the signs, because you know, it's not to say it doesn't go on to secondary infection, but it can look infected when it's not. And any open area to the skin is going to have bacterial proliferation, and it's going to have biofilm. So we've got those elements there, and those are things we need to now start to consider. So and if it's not caught and treated in time, and it's very time specific, that architecture of the skin, that scarring, you know, becomes damaged beyond repair. So the diagnostic criteria is that individuals have typical lesions in typical sites, and that it's chronic and recurrent. So we say a recent history, or you know, within the last 6 months, sort of 2 areas of boils, abscesses in those areas of HS, and that's it. You know, a lot of people are diagnosed on that. You know, so it's not so easy. The associated comorbidities that we have are metabolic disease. I mentioned that with obviously obesity in there, diabetes, increased blood pressure, cholesterol. Cardiovascular disease. People with HS have double the rates of cardiovascular disease, so it's important in the clinic that they do cardiovascular screening. Gastrointestinal disease, so there's the inflammatory bowel, Crohn's disease. Thyroid, polycystic ovary syndrome. Now that is a one to note. The rheumatological type diseases, lupus, which comes with its own skin conditions and issues, and then malignancies, lymphoma, and sometimes the sites can go on to squamous cell type of carcinomas. So associated with HS. Now, the mental health of patients, we can't stress enough how, you know, this does affect people. And there was a study done through Europe of, it was 908 patients, and these are the things they were telling us, these are the words of how it affected them. People become depressed, they're saying they've got anxiety, they're saying that they feel it's led on to other disorders such as schizophrenia. Obviously, loneliness, the isolation, the effect on the body image, the self-esteem, you know, they're saying they feel ashamed, there's a stigma to it, and sometimes they turn to substance abuse and alcohol, and the suicide rates are double people with HS. And again, one of the ladies that I saw, she was in her early 40s, and she came in and she just said, you know, she said, I've had enough. I can't cope with this anymore. And she said, I can't have people often don't have relationships, or the relationships break down because this is something occurring in intimate areas, and you can imagine that when we're teenagers and young adults, we form our relationships and friendships, don't we? We want to be doing, well, I didn't want to be doing sport, but you know, some people do, but swimming and, you know, holidays and just life, you know, going to school, university, going to work, and you know, people are withdrawing into themselves. And one lady I talked to, and she's in her 20s, and she says, well, I put on weight because when I'm having my flares, I don't want to see anybody, I don't want to go out, I'll sit at home. And what do? We comfort eat, don't we? Yeah, we do. So, you know, so it's all interlinked and related, but yeah, can't underestimate how the effects of that. you know, it's got those physical symptoms, the pain. People say, and we do pain scores, don't we, 0 to 10, and we should do them on all our wound types. In HS, it's like off the scale of pain. People can't sit down, or, you know, like the lady, she couldn't lift her arms up. The leakage, it leaks so much to these lesions, so how high volumes. Now you think you're going about your daily lives and things, and you've got that leakage from your, you know, in your armpits, your groin, you know, around your bottom, difficult to manage, and there's malodor attached to it. The skin becomes very itchy, and then we've got that scarring, disfigurement, and fatigue, because all of this is absolutely exhausting. There is a classification system. There's a few, to be honest, and actually there's a dermatological professor called John Ingram who is based in Wales, and you know, I think he might use different ones, but this is the one widely used, and it's called the Hurley staging. And you know, it's like I say, it's not easy to use, but stage 1 is like there's just single isolated lesions. We've got no tracking, and its skin's not open at this point, so it's like those comedones, the blackheads. And then we've got stage 2 with a single or multiple lesions, and then stage 3 when it's that widespread open areas. And there's talk of a stage 4, and whether that's going to be the scarring element, I'm not so sure yet. So what's the treatment? What do people have? Well, we need those initial management. So if somebody does get diagnosed by going to their GP, often they'll get referred into dermatology, if I'm honest. But, you know, if they have a GP with a special interest in dermatology, and we're trying now to get this awareness out all over, and especially into primary care, you know, they would do things like the quality of life tools. Dermatology have great quality of life tools for which we can adapt and use within wound care. Information leaflets we need. There are some, you know, we need HS organisations. The main one that was there has fallen apart, so there's little ones here and there, mainly patient-led, kind of, you see them on Twitter and things. But from a medication point of view, antibiotics are often given first line. And it's not flucloxacillin, you know, QDS for 2 weeks like we do for cellulitis. It doesn't work for this. It's a particular types of antibiotics, and it doesn't always work for everybody. And bearing in mind we've got an antimicrobial resistance and stewardship, we have to be mindful of that. Things like antiseptic washes have always been given. Hibiscrub has been widely used, but, you know, obviously we have many more of antiseptic type washes available to us. You know, and I'm not here to talk about the biologic treatments that we have, and to be honest, there's more and more being looked at by pharmaceutical companies now, which is a good thing. So we've got wound management, we'll talk about in a minute. That's smoking cessation, because we know we've got research papers to say it does exacerbate it. If applicable, weight management, and depression and anxiety screening, and the cardiovascular risk too. So we've got the BAD guidelines, the British Association of Dermatology, which say to us, you know, if initial treatments are not having any effect, then somebody needs to be referred into dermatology. Now, we know through the past few years and with COVID how there's pressure on all our services and the wait lists and things, so, you know, that is a factor. There are tumour inhibiting type biologic drugs that were used, again, work for some, not for others, and people then can be referred for surgical treatment if these are not having any effect. Now, I said I did the clinic alongside with a plastic surgeon, and and the thing is with surgery, it won't get rid of the HS, but it might give people some relief and some better quality of life. So we've got incision and drainage, which is just kind of a quick release. Now, you know yourself, if you've ever had a boil or an abscess, and it's at that point when it's so painful, isn't it? And you think, oh, I just want it to burst or something. But people often have to go to A&E and wait for things like that. And, you know, that's obviously, we know the pressure's there. We've heard about people wanting to lance their own boils, been advised to do it, the infection risk. If that was in the femoral area, you know, it doesn't bear thinking about, does it? There's electro-type surgeries, there's de-roofing techniques, and then widespread, you know, the wide excisions in plastic surgery, which might be grafted, but as I said, the HS is still there, and it might just come back in another area. So what about wound care? You know, kind of where are we? Well, this is where we've been. This is it. So people are either prescribed, if they get a prescription, of like an island adhesive dressing. So you can imagine, well, you can see with the leakage there, it's not really absorbing much of the leakage. Also, it causes that skin stripping. It causes the MARSI, the medical adhesive removal skin injury, because it sticks like glue. So it's not particularly ideal. So there's research on what wound care means for people, you know, how it affects them, and 98% of people say in the report had very, very high levels of pain during their, you know, just changing the dressings. People have been improvising using kitchen roll, toilet rolls, sanitary pads, you know, continence pads, all these different measures, because they don't know about wound care. They don't know how to manage it. They'll go to the chemist and say, can I have some dressings? And they'll often get the island dressings, or the GP will prescribe that. So we have these challenges as well. Is how do you keep a dressing in those areas like the axilla, like the groin? And we know with other wounds, it's very difficult, isn't it, to dress and keep a retention, absorbent dressing in this area. So people try and makeshift with bandages and kind of make their own like little, you know, kind of garments out of the, you know, tubifast and things like that, but then they fray and, you know, they're not ideal. So what can we look out for, and what can we advise people look out for? Well, I can say that we've been on a real journey in the past 14 months with this, and I was actually privileged to be asked to be part of a working group for a consensus document on HS and the whole management of that, and wound care has its own big section within it. And so that's good. And on the day-long stand, if you go there afterwards, they have got the documents there. So we can look out for those clusters of blackheads. And you think, well, yeah, you know, that's easy to say, isn't it? But you can really see them in areas like the axilla, places where you might not expect to see them. And then small lumps, then that kind of bursts, you know, red swollen areas, that erythema. And then, you know, that swelling increases more and more and more, becomes very tender and painful, and then it starts to leak that pus and blood. So we've got bulky dressings, we've got staining onto clothes. You know, one lady said to me, she says, I went to a party when she was younger, and the dressing, it was like in the groin area, and it dropped out. Yeah, you know, this is the thing, and we can see the MARSI, the skin stripping on that last picture there. I mean, I must tell you a case study and a story of a lady that I do know, and she first identified something wasn't right, and kind of these lesions and boils and things, when she was 12 years old. And she thought it was her fault or washing, and she withdrew, she was sporty, withdrew from that. And it wasn't until she was 17 and these areas spread, and then she had some infection. She told her mum then at 17, and her mum whipped her off, you know, to the GP. She didn't get diagnosed until she was 23. And she was referred into like colorectal. They thought it was subcutaneous Crohn's. It was kind of, she had in her axilla but round in her groin and buttock area, and had, I think, about 13 surgeries, something like that, you know, if you can't take too lightly. Lots of biologic treatment, you know, and now, you know, approaching 40s. And she said, and when she was diagnosed, it was like a relief to put a name on it. I've got this diagnosis, but then bittersweet, because it was, you know, this is lifelong. You know, it's you're going to have to, you know, you're going to go through a real journey with it. So, you know, people are changing dresses multiple times. And you imagine, you know, some workplaces, you can't, you know, you only have so many loo breaks and stuff, don't you? We know it's like when you work in out in, in our world, how hard sometimes that is. So having to go, go and to change dressings is definitely an issue. So we've got, what have we got? Well, we have amazingly got these new wound management options to us. And we have something called HydraWare. And I'm happy to talk about this stud here because there is, there's nothing like it, and it's specifically for HS. So what is it? It's, well, I think to demonstrate it, I have a model, everybody. Georgina, thank you. She's going to sashay up and down. There she is. So Georgina is wearing the HydraWare clothing. So she hasn't had her T-shirt with the moths at it. So we've got a T-shirt. We've also got, hang on. Oh, we've got shorts as well. So we've got shorts. There's shorts for ladies, shorts for men, T-shirt. There's a lovely little crop top. It's really soft and beautiful material, so we don't get that friction issue. Seams are on the outside. And then why are the holes there, you might ask? Well, this is the clever bit. So we have these superabsorbent dressing pads, and you put the clothing on, and you put that, say, like that's here in my arm, I'll put that inside, and then we've got these little Velcro connectors. They go through the hole and on the dressing, it keeps it in place. Absolute genius, isn't it? And the person who invented this has HS herself, and she did it for the good of the people who were living with this terrible condition. So, we've got a bigger dressing now, which is great. So things are being adapted and changed through it. So we're making strides forwards with HS. So our call to action to you today is just to say what a devastating condition that this is. That faster diagnosis will aid, progression of the disease. It will, have such an impact on the quality of life, which I think obviously you've gleaned from, the stories of the patients that I've been telling you today. So, so there we have it. Have people experienced an outbreak of boils in the past 6 months? Were there multiple boils, and where were they located? Were they in any of these areas? Because people often say to us, we don't have any HS in our trust. We don't see patients with HS. Now, I would pretty much argue that there are people with HS in all our areas, maybe in our lives, but in a patient situation. Do we have patients with boils and abscesses in their armpits, in their groins, around their buttocks? Yes, we do, don't we? We all do. And have they been having multiple surgeries for something else, or been given loads of antibiotics and just been misdiagnosed? So, we can improve this together for sure. There are some support groups for us as clinicians, and also, some information for patients, but we are working on this, and it is going to get much better. So thank you very much, and if there's any questions anybody wants to ask to share with the room, and if anybody wants to speak to me or Mark or Georgina from Day Long After, then do please seek us out for that. Is there any burning questions from anybody? One thing I wanted to mention as well, sometimes I forget this, and it's important, is that also you can sometimes get secondary lymphedema because of HS, and I've seen it with men with from their groin area and testicular lymphedema. And there's a session this afternoon about that, and Jane Wigg, who's the professional in lymphedema, she mentions it as well, HS. And so, we have to think about all these other things and how do we manage that within it. Any burning questions right now from anybody? I've stunned you all into silence. Well, thank you very much. Enjoy the rest of your day, and I'll see you later.